Thank you. Good morning, everybody. And if I'm a little tired, it's because I was out with my Canadian cousins last night to all hours. And so I was actually born in Sarnia, Ontario. And I didn't live there long enough, very long, but I lived there long enough to learn to speak the language fluently. So last night I utilized my serviette frequently at dinner with my cousins. But I have all on my mom's side, all these Canadian cousins, and the Canadians just have way more stamina for staying out late than I do. And so, but I'm here, and it's really nice to be in Toronto sharing this with you guys. So Betty asked me to come and speak to you guys about the basics of WM. So the purpose of my talk will be to set the table for the speakers who are way more capable than I am in this field, who follow, and just sort of cover the basics, make sure we all have a sort of the normal information that we need to understand the rest of what's going on in the forum. Okay, so I point this somewhere. Oh, it's not on. Hang on. This might help. Okay, Jay. There we go. So it's
just forward and backwards.
Got it.
Okay.
So what am I missing here, Jay?
I'll bring the computer closer.
So anyway, so we're going to describe the roots. Now, I can't see my slides except for looking over here, so I apologize when I look over here. But we're going to describe the roots underneath WM. We're going to talk about the incidence of WM, how we diagnose it, what the symptoms are, when we think about treatment. We're going to touch a little bit on genetics. And genetics are kind of important, and speakers to follow are really going to delve into that greatly. And then mostly this is a refresher course for your veterans and a basic course for the newly diagnosed people to get the most out of today's ed forum. So what is WM? So WM is a blood cancer. And blood cancers are cancers that arise out of cells that are usually found inside our bone marrow or sometimes our lymph tissue. And what happens in lymphoma or any blood cancer is that a cell becomes mutated and it decides that it's not going to follow the rules anymore. And normally this occurs by chance. So and people say, well, how did I get this? I always say, well, it's bad luck. You got this through bad luck, which is generally speaking true. And so what happens in the case of WM, you have these cells called lymphocytes, and they get mutated, they become abnormal, they decide that the rules don't apply to me anymore, and they begin to grow uncontrollably. They grow way beyond the level that they're supposed to, and not only do they grow too much, but they decide that we're not going to die either. And so cells are supposed to go through a normal lifespan, right, where you are created, and then you live for a while, and then you get turned over. That's what cells do in our body. But in WM, these cells grow a little bit more than they're supposed to, and then they accumulate this protein inside, and it's called BCL2. And the BCL2 tells them, you know, you don't need to die, just hang around for as long as you want and cause trouble. That's what happens in WM. So in WM, the hallmark of WM is that these cells make something called an antibody. We've all heard the term antibody before. It refers to proteins that help us fight infections. And these antibodies, there are many different kinds, but in WM it's only one kind, and that antibody is called Igm. So all of us here know about our Igm level, and these abnormal WM cells make the Igm. And it's named after Dr. Waldenstrom, whose picture I always get to show first when I do my ABC talk, and this is Dr. Waldenstrom. And I don't know if Steve's going to talk about when his fellow talked to us at last October, which was just humbling when he was at the conference that Steve puts on in October. So what is WM? You have a rare lymphoma. It's 3 in a million, or 1 in 300,000 individuals get this lymphoma. In the south of the border, safe from the invasion from the northern hordes across our border, we have 1,500 new cases diagnosed each year. The median age is in the mid-60s. Most are males, most are Caucasians. And in about 1 in 5 people with WM, if you dig around, you can find another blood cancer that's closely related, if not WM. So there are strict definitions for what constitutes WM. And so to have a diagnosis of Waldenstrom's, you have to have a type of lymphoma in your bone marrow called lymphoplasmacytic lymphoma. It's a very specific kind of lymphoma, not a common one. And not only do you have to have lymphoplasmacytic lymphoma, but it has to make this protein called Igm that we can detect. There are lymphoplasmacytic lymphomas that do not make Igm. There are lymphoplasmacytic lymphomas that make IgG. That's not Waldenstrom's. It's a little different disease, okay? And so for Waldenstrom's, you have to have this lymphoma called LPL, and you have to have IgM, those two things. And so naturally, a bone marrow biopsy is required to make the diagnosis to find those cells. Once we make a diagnosis, and we have to ascertain whether or not our patient is symptomatic or asymptomatic. And the term if they're asymptomatic that we utilize is smoldering. So all of us in our practice have a lot of smolderers. And so those are people who have Waldenstrom's. They meet the criteria for having Waldenstrom's, but they are not having any symptoms. We'll talk more about that later. There's also something called Mgus or Mgus if you're Dr. Ansel from the Mayo Clinic. And Mgus, we'll talk about that in a second also, which is not WM but can turn into WM. So the thing about WM is that it has a very unique way of looking under a microscope, because there are two distinct populations of cells that we see when we look under a microscope. And one of those are plasma cells that are indicated right here. See if this, there we go. And plasma cells have this thing called the nucleus pushed way over to the side. And then you have these cells called lymphocytes where the nucleus takes up almost the whole part of the cell here. And they're all related, but you see these two distinct populations of cells. So what causes WM? Most cases are sporadic, meaning you're minding your own business and you got it by chance. And what I usually tell my patients is you got it through bad luck. We have in the States a number of Vietnam veterans who have WM, and I think there's a clear, in my opinion, relationship between Agent Orange exposure and WM. About 20% of cases are familial, and what I mean by that is you can find a first-degree relative who has WM or a closely related blood cancer like WM. And the main factor for developing WM is the presence before or antecedent presence of something called IgM Mgus. So this is one of the many slides I'm going to borrow from our next speaker, Dr. Treon. And this is a study that was now, published 13 years ago. Where they looked at a number of patients with WM, dug around and found when you have another blood cancer, whether there's different kinds of blood cancers, and most of those in the blue are the WM, of course, but you can find other types of non-Hodgkin lymphomas. You can find multiple myeloma, chronic leukemia, acute leukemia, Hodgkin lymphoma. And so you can find, if you take a careful family history, you can identify these individuals. So I want to give a brief word on familial WM because it comes up every year at educational forums like this. And one person who speaks very often with the IWMF is Dr. Mary McMaster, who is at the National Cancer Institute. And she is very interested in studying families. I know other laboratories are as well. And the most important thing is at the bottom, where there's a concept in medicine which is relative risk versus absolute risk. And so patients often ask, wait, if I have WM, do my kids need to be tested? Does my brother need to be tested? Does my uncle need to be tested? Because you said it can run in families, right? And so the thing to keep in mind is you have a 3 in a million cancer already. And if your chance of getting, or your relative's chance of getting a similar cancer is 5 times higher, that becomes 15 in a million. Is it really worth testing people for things that are that rare? And so Dr. Kyle, who really is the godfather of this disease in our country, often says there is no additional risk, and that's what I tell my patients as well when they ask me about testing family members. There are some exceptions. So what happens in LPL and these lymphoma cells in Waldenstrom's, how do they misbehave? Well, they're clones of each other, and they take over the bone marrow. They try to take over the bone marrow. And so normally the body keeps perfect inventory of the number of cells that it has in the body and in the bone marrow. But in WM, these cells have mutated, they misbehave, and they decide, no, we're not following the rules, we're going to take over the marrow. And so these lymphoma cells, as they take over the marrow, can actually cause symptoms, and we'll talk about that shortly. But they also make this protein called IgM that can cause different symptoms. And so the last bullet point, which is very important, is that these cells sometimes that are slow growing might further mutate and become fast growing, and that's called transformation. And transformation is a very scary thing for slow-growing lymphomas, including in WM, and we'll talk more about that a little bit later as well. So what are these antibody proteins that I talked about? Well, antibody proteins are also called immunoglobulins, or Igs. So you have an IgM, but there are other Igs or immunoglobulins out there as well. And they have names like IgG, IgA, IgE, and IgD. And you look at these, and all these immunoglobulins are comprised of something called a heavy chain, depicted in blue here, and a light chain depicted in this light green or gray. And the heavy chains and light chains get together, and these are normal antibodies that go help us fight infection. And you look at this one, then you look at your protein, your IgM protein, and immediately you can tell it's different from all the others. And what's different about it is that it forms something called a pentamer, meaning that 5 of them get together to form the IgM protein. And why is this important? Well, you can think about the bigger these molecules, if they accumulate in your blood at very, very high levels, these protein levels, you can think about it maybe clogging things up or making the blood thicker and not flow as well. Now it's called hyperviscosity that some of you may have heard about with WM. And we'll talk about this in a few minutes. And the reason the hyperviscosity is more of an issue in WM than in other diseases that make antibodies is because there are 5 of them stuck together. There's this pentamer. So your antibody is different from all the other antibodies, for example, in people that have multiple myeloma. So normally these antibodies we all have them in our body. We need them to help us fight infection. And normally we have a nice mix of all different kinds of antibodies. The term we use for that is called polyclonal. And in WM, what happens, since all the cells in the bone marrow that make these antibodies are identical to each other, they're clones, what happens is you have one type of antibody, and so we call that monoclonal. And that's where the term M-spike comes from. If you guys are familiar with the term M-spike, it means you have a bunch of monoclonal protein. And we can find these monoclonal proteins on a blood test known as serum protein electrophoresis, or SPEP. And usually this is ordered by a doctor who is looking at your blood and finds out the protein levels in your blood look a little bit high, and they run this test called SPEP and identify these monoclonal proteins and then do further investigation. And this is what a normal SPEP looks like. And so in our body we have all these proteins. The most common protein by far and away is called albumin. And then out here in this region, this is the Greek letter gamma. In the gamma region, this is where most of our antibodies hang out, right here in this gamma region. When we have a polyclonal situation that's normal, it looks like a broad hump just like this. Conversely, when we have a monoclonal protein spike, in you folks with IgM and WM, you get a very sharp peak in this gamma region, and this tells the doctor that we have a problem here with the excess monoclonal antibodies, and then further investigation can show whether or not this is IgM or what it is, and lead the doctor down a diagnostic pathway. So this is what an SPEP looks like. So the other test that is often done when doctors are trying to figure out if somebody has WM is called Quantitative Immunoglobulins. What does that mean? It means measuring the antibody levels in the blood. And in WM patients, the IgM is usually high, and it does so at the expense of the other immunoglobulins like IgG and IgA. So usually the IgM is real high and these guys go low. And when these guys go low, that can lead to an increased risk of infection. And the way I explain this to my patients a lot of times is if you have a litter of puppies and one puppy's eating all the food, that puppy gets really fat, the IgM goes real high, and the other puppies get thin, and that's the IgG and the IgA. So that's what happens in WM a lot. So what's critical to remember in Waldenstrom's is that it occurs in phases. It goes from something called monoclonal gammopathy of undetermined significance, Mgus, to smoldering, to symptomatic. And there are strict definitions for each of these that we all follow in our field. And we only treat symptomatic patients. That's really, really important to remember. We only treat symptomatic patients. So what is MGUS? Well, MGUS is defined as by the following criteria. The M spike, your IgM level, cannot be too high. And if you have to have a bone marrow biopsy to make this diagnosis, really to be sure. And when you do the bone marrow biopsy, you find that fewer than 10% of the cells in the bone marrow are these abnormal WM cells called LPL. In addition to that, you can't be sick from it. You can't have anemia, you can't have swollen lymph nodes, you can't have an enlarged liver or spleen, you don't have thick blood, and you feel perfectly fine. You do not have fevers, chills, or sweats. So if you have these things, you have what's called an Igm Mgus, and this is pretty common, and your chance of getting Waldenstrom's over your lifetime is roughly 2% per year. That is, Waldenstrom's requiring treatment is about 2% per year. These patients are followed very carefully. Now, if you have a little bit more LPL in your bone marrow, or a little bit higher M spike, and more than 10% cells in your marrow, then you have something called smoldering, so long as, again, you are not sick or having symptoms from your WM. And smoldering disease has to be followed more carefully because it has a higher risk of transforming to WM that needs treatment on the order of 12% per year for the first few years, and it tails off after that. So I always tell my patients that have smoldering disease, if I have 100 people just like you and follow you for many, many, many years, maybe 7 or 8 out of 10, 7 out of 10 will eventually need treatment for their WM, but not everybody. And again, we don't treat smoldering disease. So how does Mgus and smoldering disease turn into symptomatic myeloma? There's a ton of research going on in this area. And one thing we know is that certain mutations may predispose to having your Mgus or smoldering disease convert to symptomatic disease. But everyone is interested in getting data. Dr. Treon's lab, Dr. Gobriel in Boston also has something called the P crowd, where she's looking for samples, and I just included information here that's available to you in this presentation and their websites. But there's all kinds of research laboratories that are interested in figuring out this question. And Steve, I'm sure, will talk more about that. So let's talk about how WM patients present to their physicians. And so it usually occurs in one of two ways. One way is that the patients come in and they say, I'm sick, something's wrong, please figure it out. And they have symptoms. That's one way they present to their doctors. Another way they present to their doctors is they're minding their own business and someone draws blood. And they draw blood and they either find a very mild anemia, which is a low red blood count, or they find an elevated level of protein in their blood and do that test called electrophoresis that I showed you a few slides ago. I call that an incidentaloma, when you're minding your own business and then someone says you're going to the blood cancer doctor. So what are the symptoms that patients usually have when they present to their physician if they have symptoms? Well, by far and away in my experience, the most common symptom is weakness and fatigue. Something's not right. I'm more tired than normal. I just can't do what I used to do. Occasionally, patients have bleeding manifestations. There are different reasons why people with Waldenstrom's bleed. It can come from hyperviscosity, and rarely there's this thing called von Willebrand's disease that maybe a few in the room may have or have had that's associated with WM as well that can lead to bleeding. Some patients present with hyperviscosity syndrome. It's not common, but it's pretty devastating and debilitating when patients present with it. And hyperviscosity syndrome we'll talk about in a few slides, but people don't come in, they usually come in saying something's really wrong, doc. Occasionally there's weight loss, which is unintentional. Sometimes they have neurologic symptoms such as peripheral neuropathy. Sometimes they have visual disturbances, my vision's not quite correct, or their fingers turn white when the weather turns cold. And then sometimes, but not commonly, they have this other disease associated with the WM called amyloidosis. And amyloidosis is not a common complication of WM, but it's common enough where the doctors always have to be aware of it, and we'll talk about that as well. Very rarely, WM can affect the central nervous system. It's important to be aware of this. And this, when it affects the central nervous system, this has a name called Bing-Neal syndrome, or BNS. And the good thing about Bing-Neal syndrome is that it's rare, but it can occur at any time point during the course of WM. The symptoms are highly variable between patients. And the scary thing about Bing-Neal syndrome, for me, is that it can show up or become apparent in patients who look like they're otherwise doing okay if you're measuring their IgM numbers or checking to see how their treatment's going. Next thing you know, something is going on, a headache or a neurologic complaint, and that turns out to be Bing-Neal. And if you're thinking that someone might have Bing-Neal, there are very important tests that have to be performed in order to make that diagnosis. And those include an MRI done with contrast. And then we have to biopsy something or do a lumbar puncture and often do special testing on that to figure that out. This is an example of an MRI of the brain of someone who has Bing-Neal syndrome and Waldenstrom's. And the normal brain is on this side over here, where it's kind of dark like this with the contrast. But when you infuse the contrast with the MRI, the parts of the brain that are inflamed or irritated by the lymphoma turn kind of white. So this is called a coronal view here. This is a top view right here. You can see all this area of the brain here. And so this patient would be complaining of stuff. So what about WM? And one thing is that it's different in everybody. So your course is going to be your course. It's going to be unique to you. And so when you get online and you read about, there's such great information out there these days for WM. You'll read about someone's experience with their symptoms or how they responded to one treatment or another treatment. That's their experience. And so it's good information to have, but you're going to chart your own journey with WM. It's really important to keep that in mind. So let's talk a little bit about how the WM does cause symptoms. So the main two ways that it causes symptoms are, these are the WM cells that we saw earlier right here, and they can just grow in your marrow and they can cause a swollen lymph node or a swollen spleen or result in fatigue or sweating. Or what can happen is the IgM that's made by the cells can cause, for example, hyperviscosity syndrome with nosebleeds, headaches, and vision trouble, or it can cause peripheral neuropathy, or these really rare things with funny names called cryoglobulinemia and cold agglutinin disease that have very unusual symptoms as well. So when we talk to someone, pardon me, who has WM, we're always in our mind going through, we ask a list of questions, and these questions are exactly the ones you see in the slide here. Do you have any of these symptoms? And knowing these symptoms helps us ascertain how best to treat a patient. Some of you in the room here have something called Igm neuropathy. And Igm neuropathy is, I was telling Dr. Treon this morning, it's the most frustrating thing that I think that I deal with in my practice, because it's tough to figure out sometimes, and it's really tough to treat sometimes. The clinical course is quite variable. When people have neuropathy with IgM, very often they have it just with the Mgus, not with the full-blown WM. And there are different kinds of Igm neuropathy, just to make matters more confusing as well. You can have neuropathy with or without these things called myelin-associated glycoproteins. You can have something called DADs. You can have neuropathy associated with this antibody called GM1. These diagnoses overlap symptomatically. The clinical course is variable. They can be quite debilitating over usually years. And treatment is variably effective, and it works better for some treatments, for some types of neuropathy, than for others. And so I just mentioned this slide here just in case, because there's always some people at these educational forums who don't have frank Waldenstroms, but they do have an Igm neuropathy. So if someone has, we think someone has WM, what is necessary to do to work them up? Well, one thing we have to do the blood work, of course, and then we also have to do urine work. And the reason we do urine tests is because sometimes patients have this thing called amyloidosis that can only be detected with the urine test. And sometimes the LPL or the WM cells can directly irritate the kidney. So it's important to do urine tests. And then bone marrow biopsy with the testing of a gene called MYD88. And occasionally we do CAT scans or CAT scan PET scans, although they don't help us out terribly much in WM compared to other lymphomas. But by far, far, far and away, the most important thing when we're talking about to our patients is to actually talk to and listen to our patients. That's the most important diagnostic part of the workup by far and away, because our patients will tell us almost invariably if they need to be treated or not, if they're symptomatic or not. Those cousins kept me up too late last night. Anyway, and amyloidosis is something I've mentioned a couple times here, and it's beyond the scope of my talk here, but there's something called the torch. And the torch is a couple things from the torch from the IWMF in the back table I saw there. And in the torch, there are two great articles on amyloidosis if you're interested, one written by Dr. Merlini and one by Dr. Gertz. Other important tests to look for rare complications of WM include cryoglobulin testing, cold agglutinin testing, testing for bleeding, and those neuropathy tests that I mentioned as well. This is another resource available through the IWMF for understanding your blood test, which is so critical. Because one of the things that I do when I see a patient with WM is mostly try to educate them about what their disease is on how to follow their disease and track their disease. And to know that, you have to understand the blood tests. So this is a resource that's available through the IWMF. Let's talk about viscosity, because we mentioned hyperviscosity is a complication of WM. So viscosity measures the resistance of fluid to flow, and water, which flows readily, is less viscous and is thin, and oil flows less readily and is more viscous and called thick. And the Igm proteins, because there's 5 of them that stick together, remember that, they're much more likely to become hyperviscous and thick. And if they do so, they can cause the blood not to flow very well through the body, and that's called hyperviscosity, and it can cause headaches, nosebleeds, trouble with vision, or other serious medical problems like shortness of breath or kidney issues. And when patients have hyperviscosity, frequently they need a treatment called plasmapheresis. Has anybody here had plasmapheresis done? Yeah, and so which is a machine that removes the excess proteins to try and thin the blood out. And occasionally we have to do that, and then we have to treat their underlying disease to fix that problem. So a little bit more about hyperviscosity syndrome. This is a study that was done by doctors at the Mayo Clinic, and what they looked at is they developed a predictive system for saying, okay, who's more likely or less likely to develop hyperviscosity syndrome over time. And they identified a high IgM level above, I think, 4,600 milligrams per deciliter, 46 for you, and a high viscosity blood test as being the 2 most common predictors. And if you follow this over here, if you didn't have those, your chance of getting hyperviscosity over the next several years was virtually nil. If you had a little bit of the risk factors, then you were up here, and if you had all the points, then your chance of getting hyperviscosity was much higher. And if I focus you over to the left hand of the slide here, these are patients that they saw with hyperviscosity, and on average, their viscosity level was high, around 4. Their IgM levels tended to be higher here. The median IgM levels are almost 7,000. And 2/3 of the patients had IgM levels above 6,000 who developed hyperviscosity syndrome. And the symptoms are listed here, which are just not feeling well, nosebleeds, bleeding in the back of your eye, bleeding from your gums, vision trouble, all those things. And so that's just one technique for trying to figure out who might get hyperviscosity when they have WM. So to diagnose WM, to focus back on that, again, a bone marrow biopsy has to be performed to demonstrate the non-Hodgkin lymphoma called LPL, and you have to find IgM in the blood. These days, I think the testing for a mutation called MYD88 or MYD88 is mandatory in my opinion, although it's not part of our definition yet for diagnosis. And there's some disagreement on whether or not an additional genetic test called CR4 should be tested amongst doctors. This is a typical bone marrow biopsy report in a patient with WM that is and basically you have some cells. You have some percentage of the cells sitting in this part of the bone marrow show the nodular interstitial population with lymphocytes, plasma cells, and lymphoplasmacytoid form. This is a classic bone marrow biopsy report. I don't know if you guys have copies of your bone marrow biopsy reports at all, that you keep them or look at them. This is what a classic one looks like. Prognosis. So I always tell my patients, no matter what you read about prognosis, it's better. So whatever you read about your prognosis, it's better. And there are some clinical and lab features that we utilize in the WM community to help with prognosis, but to be honest with you, I don't find them terribly helpful. And with better therapies, we know that we can retreat patients with very effective treatment, and there's some evidence that's been recently published that shows this results in longer survival seen than in this paper that I have included here from 2009 that showed a prognostic scoring system. And if you had so many things, your survival might be this, but in my mind, this is a little outdated now with modern therapies. So I always tell people to expect a long survival with excellent quality of life when patients ask me about their prognosis. Long survival with excellent quality of life. Okay, so we're going to do a few slides on what I call onco-speak to set the table for later in the talk. And onco-speak is when doctors say things and patients are sitting there saying, I don't even know what language this is, right? That's onco-speak. And so doctors at meetings are always showing curves to patients. You know, they show you these curves on research studies, and patients will look at those and go, I don't even know what you just showed me. So we're going to try to work on this. So a very common thing shown by doctors at meetings is something called the Kaplan-Meier curve. And a Kaplan-Meier curve is an estimate of the probability of survival of a group of patients. And so here, if you look at the horizontal axis, this is time in years, you know, up to 20 years. The vertical axis is the probability of surviving, or the proportion of people surviving. And at time 0, everybody's alive. You follow me there? And at 2 years, the probability of survival is 83%. At 10 years, it's 55%. And the median survival, you hear doctors talk about the median survival all the time. Median survival is when half the people are doing okay and half the people aren't doing okay. The median survival here is 11 years. So whenever you see curves like this, normally it's better to be up here and have the curve stay up here. Does that make sense? Really high. And it's not as good to have the curve go down here if we're talking about anything that has the word survival in it. So that's a Kaplan-Meier curve. So let's look at a Kaplan-Meier curve for survival in WM. And this is from Jorge Castillo, who's in the back of the room here. He published this a few years ago. And he looked at people diagnosed between 2001 and 2010 and looked at how old you were when you were diagnosed. And so it comes in different cohorts or groups of ages, up to 80 years here, and said roughly, what was your probability of being alive after a certain amount of time? So if you're younger and you waited 10 years, almost everybody was alive. If you were over 80 and got diagnosed, by 4 years, half the people were gone, but might have been that anyway, right? And so anyway, but this is just another way of looking at survival in WM. And the point again is that it's long, and it's longer than it used to be. So let's talk, I'm going to touch briefly on treatment, but not specific treatment, but how we think about treatment. And this is how I think about treatment. And so when I see a patient with WM who's symptomatic, has those things that we showed earlier, the fatigue, the anemia, the sweats, those symptoms, I sit down with my patient, I say, what are our goals of treatment? Because your goal of treatment might be better if you're young and vigorous versus if you're older and frail. If you're really symptomatic, our goal of treatment might be better than if you just have a little bit of anemia or you're a little bit tired. And so you have to define that with your patient. The terminology I use is young and vigorous versus old and frail. And young and old are not defined chronologically. They're defined physiologically. So I live and work in Colorado, and we have 80-year-olds who climb 14ers in Colorado. And so we have to say, okay, those are 14,000-foot peaks. And so we have to figure that out with our patients. And then I have to say, okay, am I a believer when I treat patients? Do I think that I just need to make them feel better, control the symptom? If you're tired, make you less tired? Or do I think that if we have this blood cancer and we're going to treat you, that we should try to get rid of it? And so that gets debated in our field all the time about whether or not just to give enough treatment to make my patient feel better, or no, we're going for scorched earth here. We're going to try to make this thing go away. And the latter is called depth of response. So some of us are depth of response believers, and some of us are no, just make my patient feel better believers. And you have to explore that with your patient. The next thing we have to figure out is whether or not the patient wants fixed duration treatment. That is, you want it done in a certain amount of time, usually measured in months, or if you don't mind being on treatment, in quotes, forever. And so there are certain treatments that we give and we utilize in WM that once you start them, patients say, how long will I be on this? I say, well, until it quits working, or you have side effects that mean we can't use it anymore. So a long time. That's called continuous therapy. We have other treatments that are fixed duration therapy treatments that are done in a matter of months. And then there's some discussion about whether or not certain mutations, such as MYD88 or CXCR4, can influence treatment as well. So when do we treat people with WM? Well, we treat people with WM based on symptoms, not the IgM level. So the most common second opinion that I see in my practice by far and away is somebody who is diagnosed with WM, an incidentalloma. They're minding their own business and the protein was high, that kind of WM. Their IgM level's high. Their doctor freaked and said, you need to start treatment. The patient gets online, goes to Carl's IWMF website, and finds out that we don't treat smoldering WM, and goes and gets a second opinion. And so we don't treat the IgM level, we treat the patient. If the patient has symptoms or a problem, that's when we treat. So we treat for anemia, that's called a low hematocrit. We treat for low platelets. We treat if the patient has symptoms. If they have hyperviscosity, we treat. If they have neuropathy that's pretty severe, we try to treat. Or if they have toes that turn blue, or noses that turn blue, or ears that turn blue in cold weather, we treat those patients too. So the patients will tell you if they need to be treated, if we listen. And the other thing that's very important is that the IgM level in your blood, and the number of lymphoma cells in your bone marrow, those vary tremendously between patients. So you can have a patient who has a very high IgM level in the blood and hardly any lymphoma in the bone marrow. And those are very efficient producers of IgM. And conversely, you can have patients who have bone marrows that are packed with lymphoma and don't have very much IgM. And this was shown very elegantly by Dr. Treon in a paper that I love to show patients, where Dr. Treon and his colleagues looked at people who have, these are people's bone marrows. These are every little thing here, diamond is a patient. And this is the percentage of their bone marrow that's occupied by lymphoma cells from 0 to 100. And this is the level of IgM in their blood. So you see here that someone who has very little lymphoma in their bone marrow might have an IgM of 6,000. And someone here who's got a packed marrow, 80%, might have an IgM of 800. And so between patients, the IgM level and the bone marrow involvement is all over the map. Now, in an individual patient, for you, if you know your IgM level and how much lymphoma is in your bone marrow, then you can follow that. And so for you, it works for an individual patient to know this. The IgM level reflects what's in your bone marrow for the most part. And so I tell my patients, the bone marrow is the gas tank, and the IgM is the gas gauge for you, but it's different for the guy next to you who has WM. So we need to learn about mutations in 2019. There's no avoiding it. You all have to learn about mutations. You have to go back and learn about your DNA and your genetics and all that stuff. And we're talking about genetic mutations. These are changes in the DNA. They occur inside the blood cells, okay? And they're acquired. You were not born with them. Okay, you don't pass these on. These are called somatic mutations. And in WM, the two biggest ones, there are many, but the two biggest ones are called MYD88 and CXCR4. And we're learning a lot about how these mutations influence how the WM behaves clinically, that is, what kind of symptoms it might produce, and also how it responds to certain treatments. Now, the MYD88 is one specific mutation for the most part, with rare exception, called L265P, and it's present in virtually everybody with WM. Perhaps 95% of people with WM have this MYD88 mutation. The second mutation, called CXCR4, is present in 40% of WM patients, and it's way more complex. The MYD88, there's pretty much one mutation. CXCR4, a bunch of mutations. And they're different, and they may influence how your WM behaves in different ways. So we're learning a lot more about these mutations. And the genetics are way more complex than this, but this is what you need to know in 2019 if you're a patient. You need to know MYD88, you need to know about CXCR4. So this is Dr. Treon's seminal paper that described MYD88 and literally changed the map for what we do in our field. This is the Pinocchio is a real boy moment for WM, meaning that WM is a disease that people wondered if it was really its own special disease. And whenever you're a disease and you have a mutation, you're a real disease, you're a real boy, and WM is a real disease based on this mutation being found. Here's you'll be tested on this at the break, the different CXCR4 mutations. This is how many there are. And so one thing we use this genetic testing sometimes when someone has a blood cancer and we're not sure what it is. So doctors use this mutational testing sometimes. We'll see someone and we're going, does this person have WM? Or do they have Mgus? Or do they have marginal zone lymphoma? Or chronic leukemia or myeloma? And we can use this MYD88 and CXCR4 testing to distinguish them. So again, in WM patients, they virtually all have this. About 40% of them have this. But if you're myeloma, no one has this. and no one has this. And so there are cases of IgM problems that are multiple myeloma, and they're not WM. And we can use this testing to distinguish, for example, IgM type of myeloma from WM. So doctors use this testing all the time. I'm not going to show you that real quick. I'm going to show you some more oncospeak. So you'll see these later in the talks as well. One is response rate. Response rate is defined as the percentage of patients who have at least a 50% reduction in the WM we can measure. So you'll see that all the time. A treatment has a response rate. What's the response rate to Nestle's Quick for treating WM? It's 60%. That means 6 out of 10 patients had a reduction of at least a half in what you can measure of their WM. Then we talk about PFS all the time. You hear doctors all the time, PFS, PFS. What is that? It's called progression-free survival. That's how long patients went before relapsing or dying. So it's a good thing to have progression-free survival. Then we have overall survival, which is exactly what it says, dead or alive. So overall survival, remember that Kaplan-Meier curve I showed? We want it to be really high if we're talking about overall survival. Then the latter bullets here are the genetic stuff. So you'll hear terms like wild type. And so people talk about MYD88 or MYD88 wild type. What does wild type mean? Is that normal or abnormal? That's normal. So that means it's an unmutated gene, a normal gene, the one you were born with, functioning how it's supposed to function. That's called wild type. That's the opposite of mutated. So you'll hear doctors, WM doctors talk about MYD88 wild type. That's normal. MYD88 mutated, abnormal, L265P. And then we have another term, just to make things a little more difficult, in CXCR4, the mutated type we call WM sometimes. And sometimes we call the mutated MYD88 L265P. So this is just terminology that's important and I think will be helpful to have as you see the rest of the day go on here. Now, how do doctors use this information? Well, we divide our WM patients into different genetic types. So here's I'm going to walk you through this. This is a MYD88 mutated and a CXCR4 unmutated or wild type. This is MYD88 mutated, a CXCR4 mutated, MYD88 mutated, CXCR4 differently mutated, and this is MYD88 normal gene, CXCR4 normal gene. And so these are at least 4 distinct subtypes of WM so we have a rare disease and we're subdividing it based on genetics. And that's what's going on in the field right now. This latter category here is very unusual. So I think I'm going to just, in the interest of time, very quickly, I'm not going to show, these are Kaplan-Meier curves. I'm going to not spend a lot of time with these, but Betty, these slides will be available to all the attendees, will they somehow? Yeah, great. So I just, because Dr. Treon's talk is way more important than mine. I want to talk a little bit about transformation. And one thing we know about, if you have Waldenstrom's and you don't have the MYD88 mutation, your risk of transforming to more aggressive lymphoma is higher. So that's 10% of all WM patients, okay, who fall into that category. So we have to, not having the mutation, maybe it's 5%. And so we have to watch those patients pretty carefully and make sure they don't develop signs of transformation. So what else do we know about these patients with WM who don't have the mutation? Well, first thing is if we think a patient has WM and they don't have the MYD88 mutation, we better make darn sure they don't have multiple myeloma, because these patients might have multiple myeloma, up to 3 in 10 might, and there's very specific testing that we have to do to make sure that we have the correct diagnosis. I'm going to stop right there, you guys, and then I don't know, I think we're on a pretty tight time schedule, and are we going to do questions later? Betty's part of the panel.
You've got 5 minutes for questions.
Okay. So I'm going to stop right there. And any questions? Okay, thanks.